Imagine looking under a microscope at just a single tiny slice of human tissue and witnessing like a total biological paradox.
Oh, it's completely baffling when you actually see it.
Right,
Uh,
because on the very surface, the skin is just crumbling. I mean, it's atrophying and thinning out like fragile, crushed tissue paper.
exactly, just completely degrading.
But then, in the exact same millimeter of tissue, right below that crumbling surface, the deep layers are doing the exact opposite.
Right, they're rapidly overproducing dense, rigid collagen.
Yeah, essentially turning the foundational tissues into stone. So you have a disease that destroys the surface stacked directly on top of a disease that solidifies the depths.
It's a medical impossibility, honestly. Or at least it was supposed to be.
Exactly. And today we are looking at this paradox because it is forcing dermatologists and researchers to completely rethink how we categorize autoimmune conditions. Welcome to today's deep dive.
I'm really excited for this one. We are diving into a notoriously murky area of dermatology today.
We really are. For a long time, the medical community has treated extragenital lichen sclerosus and localized scleroderma, which is better known as morphea, as two completely distinct, separate entities.
Right, but as that microscopic paradox shows, the boundaries between them are just, well, they're far more porous than the textbooks suggest.
So if you are navigating an autoimmune issue, or, if you just find the diagnostic detective work of medicine fascinating, this is a perfect case study for you.
Absolutely.
We're taking the latest insights from the British Association of Dermatologists, clinical data from the Mayo Clinic, and some truly paradigm-shifting histopathology case studies. We're going to explore how these two shape-shifting conditions trick the naked eye.
And more importantly, we're going to look at why telling them apart is such a profoundly high-stakes game.
Yeah, the stakes are wild. But before we get there, we first have to understand the specific mechanisms driving these two conditions, right?
We do. So let's look at extragenital lichen sclerosus first, or LS.
Okay, let's start there.
Now, most people in the medical field know LS primarily as an anogenital condition, particularly affecting postmenopausal women. It's usually characterized by severe itching and structural changes.
Right, that's the classic presentation.
It is. But in about 6 to 20% of cases, it actually presents extragenitally.
Which means like on the trunk.
Right, exactly. On the back, the shoulders, or under the breasts.
And that is a completely different clinical experience for the patient, isn't it?
Completely different. The extragenital presentation is often totally asymptomatic.
Oh, wow. So no severe itching at all.
Usually no. It just appears as these shiny, porcelain white, wrinkled plaques.
I read in the sources that the texture is often compared to cigarette paper.
Yes, that's the classic textbook description. And that crinkled texture happens because LS is fundamentally a disease of superficial destruction.
Right. The immune system just attacks the top layer and the superficial dermis just below it, which causes that localized atrophy.
Exactly. Now, contrast that with our other primary suspect, morphea.
The concrete pore.
Right. Morphea is a rare inflammatory connective tissue disorder. And in its early active phase, it announces itself quite differently.
What do you usually see early on?
You'll often see this lilac ring, like a violaceous erythematous halo.
A purple ring, basically?
Basically, yeah. But it isn't just a color change. That lilac ring is the visible perimeter of an active inflammatory fire that's just spreading outward.
Wow.
And instead of thinning the surface like LS does, morphea triggers this massive overproduction of collagen deep in the reticular dermis and the subcutaneous fat.
Okay, I want to try a mechanical analogy here to help visualize this. Think of the immune system in these diseases like a rogue construction crew that just received, corrupted blueprints.
I like that. Let's hear it.
So with LS, the crew is sent to the roof of your house. They start tearing off the shingles, damaging the weatherproofing, that's your superficial atrophy, and the crinkly surface, right?
Spot on.
But with morphea, the rogue crew bypasses the roof entirely. They go straight into the basement and start pouring thousands of pounds of rigid concrete.
Yes. They replace all the flexible foundational tissue with dense, immovable collagen bundles. It's a great analogy.
It helps me picture it.
Well, and following that rogue crew analogy down to the cellular level actually explains the specific visual clues dermatologists look for.
Oh, really? How so?
Well, because the LS crew is wrecking the roof, they disrupt the normal shedding of skin cells in the follicles.
Okay, so things get backed up.
Exactly. This creates follicular plugging, these keratin plugs trapped within the hair follicles. They look almost like dark comedones or blackheads embedded right in the white plaque.
Gross, but fascinating. And the morphea crew?
The morphea crew, since they're pouring concrete in the basement, they cause such intense deep tissue fibrosis that the swelling literally strangles the hair follicles and sweat glands from the root up.
Wait, it just completely destroys them.
Completely destroys them entirely.
Okay, so in the early stages, the evidence of the crime is pretty distinct, right?
Very distinct.
You have a superficial attack with keratin plugs on one hand versus a deep tissue hardening with a lilac inflammatory ring on the other.
Right.
The diagnostic challenge seems entirely manageable at that point. But the clinical data shows that dermatologists actually frequently struggle to differentiate the two when a patient comes in with a hardened white patch on their back.
They really do. The naked eye just fails.
Why does it fail if they are so anatomically different?
It fails because these diseases are chameleons, honestly. The distinct early phase presentations blur into indistinguishable chronic phases.
Indistinguishable.
Pretty much. When morphea burns out its active inflammatory phase and becomes chronic, that massive deep tissue fibrosis doesn't just stay in the basement.
It moves up.
Yeah, the remodeling and collagen deposition expand upward, and it eventually compresses the superficial dermis.
Oh, I see. So this upward pressure causes changes on the surface that beautifully mimic the shallow, paper-like atrophy of LS.
Exactly. It fakes the roof damage.
And LS pulls the exact same trick in reverse, doesn't it?
It does. A chronic, long-standing LS lesion will eventually cause the deeper collagen in the upper dermis to thicken and homogenize in response to all that constant superficial damage.
So your roof problem suddenly causes the underlying supports to swell and harden, mimicking the deep concrete pore of morphea.
Yes, so by the time a patient actually gets referred to a specialist, the initial clues, like the lilac ring or the pure superficial crinkle, they're just masked by this uniform, hardened white plaque.
But wait, let's look at the treatment protocols for a second. I was reading that both of these chronic conditions are frequently treated with highly potent topical corticosteroids, like clobetasol, right?
That's right. Or sometimes targeted phototherapy to suppress the local immune response.
So if both diseases eventually look like a hardened white pouch on the shoulder and both get a heavy dose of topical steroids, why does the label even matter?
Well, it matters.
Are we just splitting hairs over medical terminology here?
No, not at all. The label dictates the entire trajectory of the patient's long-term care, and the consequences of getting it wrong are severe.
Severe how? Let's talk about morphea first.
Let's examine the progression of morphea. Because the pathology originates deep in the connective tissue, it has the potential to aggressively extend beyond the fat layer,
Meaning into the muscle.
muscle, and even bone. In subtypes like deep morphea or linear morphea, that fibrotic concrete can bind to the underlying fascia, infiltrate the muscle tissue, and actually reach the bone.
Which fundamentally alters the mechanics of the body.
Profoundly, especially in children whose bones are still developing. A misdiagnosed linear morphea on a limb can cause severe joint contractures.
What does that look like?
It's where the limb physically locks in a bent position because the tissues have essentially fused together.
Oh my God.
Yeah, it can cause permanent growth asymmetry, leaving one leg significantly shorter than the other. You cannot reverse that level of structural damage with a topical steroid cream.
Right. It's not going to cut it.
Not at all. You have to halt the rogue immune response systemically. That often requires aggressive systemic immunosuppressants like methotrexate or, systemic corticosteroids.
So treating that with a topical cream is like trying to put out a basement fire with a spray bottle.
That is exactly what it's like.
Then let's flip the scenario. Let's say a clinician looks at a plaque on the back, assumes it's just mild morphea, and doesn't investigate further. But the lesion is actually extragenital LS.
Well, that oversight misses a massive diagnostic red flag.
Because of the cancer risk.
Partially, yes. While the extragenital plaque on the back isn't inherently dangerous itself, the clinical guidelines emphasize that patients with extragenital LS have a very high statistical likelihood of having concurrent, sometimes asymptomatic, anogenital LS.
Right. And the genital variant of LS carries a documented 5% risk of malignant transformation into squamous cell carcinoma.
5% risk of skin cancer.
That's huge.
It is. If you mistakenly label an extragenital LS patch as morphea, you are highly unlikely to perform the necessary genital examinations.
Because why would you if you think it's morphea?
Exactly. You'd completely miss the window for cancer surveillance.
Yeah.
So the distinction is absolutely not semantic.
It is literally the difference between implementing aggressive systemic therapy to save the function of a limb versus initiating long-term cancer screening to save a life.
Bingo.
The stakes are incredibly high, the visual overlap is maddening. So how does a specialist actually secure the truth? When you can't trust the naked eye, you have to augment your vision.
You do. And that brings us to the first line of defense in the detective's toolkit, dermoscopy.
I love dermoscopy.
It's amazing. Dermoscopy utilizes polarized light magnification. And the polarization is key here because it neutralizes the surface glare of the skin.
So it lets you see past the very top layer.
Right. It allows the clinician to look directly through the stratum corneum and visualize the vascular and structural patterns operating just below the surface.
And under that polarized lens, you really start to see the mechanical differences in how the tissues are failing, don't you?
You do. In LS, the dermatoscope reveals what clinicians call white structureless areas.
Which represents the epidermal atrophy.
Exactly. But the defining feature is the vascular pattern. Because the top layers of skin are so thin and fragile, the tiny capillary loops in the superficial dermis become highly visible.
Then they look weird, right?
Very weird. They're distorted. They twist into these very specific comma-shaped or hairpin-like vessels.
Okay, so comma vessels for LS. What about morphea?
Morphea, due to its deep fibrotic nature, completely lacks those delicate comma vessels.
Because the collagen blocks them.
Yes, the dense collagen overproduction physically obscures the superficial capillary network. So instead, the polarized light reveals thick fibrotic beams.
Fibrotic beams.
Yeah, you are essentially looking down into a dense interwoven network of rigid white collagen tracts.
Okay, so dermoscopy gives you the structural topography, but to truly understand the chemical and cellular reality of the lesion, you have to extract a sample.
You do. Histopathology, taking a punch biopsy and looking at the tissue vertically under a microscope, remains the gold standard for separating these two.
And the microscopic view of LS is highly distinct, isn't it?
It is. Pathologists look for a classic red, white, and blue pattern.
Which I think perfectly illustrates the mechanics of the disease. Let's break that down for the listener.
Sure. So the red is hyperkeratosis at the very top.
Meaning the skin's normal shedding process is completely broken.
Right. So a thick layer of dead keratinized cells accumulates on the surface, which stains red.
Okay, and the white?
The white is a wide, pale zone just below that, where the superficial dermal collagen has homogenized and filled with edema.
So it looks washed out and structurally weak.
Exactly. And then the blue at the bottom is a dense, band-like infiltrate of inflammatory lymphocytes.
It's literally an army of white blood cells camping out in a horizontal line, staining dark blue.
That's a great way to describe it. You also see significant damage to the basal membrane, which is the crucial border separating the epidermis from the dermis.
Right. The immune attack causes it to degenerate, creating these jagged invaginations that look like small teeth dipping into the dermis.
Yeah, it's very chaotic on the surface.
But slice into a morphea lesion, and the microscopic architecture is entirely different.
Entirely. In morphea, that basal membrane is generally perfectly intact.
Because the surface layer is essentially oblivious to the chaos happening below.
Exactly. You won't see the red, white, and blue pattern at all. Instead, you look deep into the reticular dermis and the subcutaneous fat.
Down in the basement.
Right. And there, you find massive, swollen bundles of eosinophilic collagen. They are these thick, pink beams that have completely replaced the normal, airy, fatty tissue.
And where are the inflammatory cells in this scenario?
Well, they aren't in a neat blue band at the top, like in LS. They are trapped and squeezed tightly between these massive collagen pillars deep down in the tissue.
Okay, so we have clear mechanical differences, epidermal destruction versus deep collagen deposition. We have clear diagnostic tools, the comma vessels versus fibrotic beams,
Right.
the red, white, and blue atrophy versus deep swollen collagen. It feels like we have a really reliable map to navigate this diagnostic landscape.
It does feel that way.
But recent research forces us to throw that entire map right out the window.
Yeah, this is where the standard categorizations break down entirely.
Let's talk about the plot twist. A case study published recently in the journal Curious details a scenario that just defies the standard biological rules.
It's a fascinating case.
Right, so a 60-year-old female patient presented with a single, well-defined sclerotic plaque on her vulva. Clinically, it was a textbook presentation of genital LS.
Severe itching, porcelain white color.
Exactly. So the clinicians performed a standard punch biopsy to confirm the diagnosis.
But the histopathology results presented an impossible picture.
Impossible how?
Well, the biopsy didn't just show signs of LS, and it didn't just show signs of morphea. It showed the defining microscopic features of both conditions simultaneously,
Wait, like in the same spot?
occupying the exact same vertical column of tissue.
That is wild. The microscope revealed the superficial epidermal atrophy, the hyperkeratosis, and the basal cell degeneration of LS, sitting directly on top of the deep, massive, inflamed collagen bundles characteristic of morphea.
Yes, the roof was caving in, and the basement was filling with concrete, in the exact same millimeter of the body.
How is that even possible? I mean, how rare is this?
Well, for context on how rare this is, we do have epidemiological data showing that patients can develop both diseases independently.
Okay.
Like, research by Kreuter demonstrated that roughly 6% of patients with morphea also have distinct LS lesions elsewhere on their body.
6%, okay.
And another cohort study by Lutz found that up to 45% of morphea patients had concurrent separate genital LS.
But finding them on different parts of the body is one thing, right? You can just chalk that up to a generally overactive immune system.
Exactly.
But finding them perfectly superimposed in one single solitary lesion, that hybrid pathology is a massive disruptor to how we define these diseases.
It is. The existence of a hybrid lesion demands that we look at the leading theories emerging from molecular biology. We really can no longer view the co-occurrence of LS and morphea as a mere coincidence.
Right. It is incredibly unlikely that a patient is struck by two completely independent, highly specific autoimmune diseases in the exact same localized cluster of cells.
The prevailing theory now is that LS and morphea share identical underlying pathogenic machinery.
Meaning they share the exact same genetic predispositions and immunological triggers.
Precisely. Specifically, researchers are zeroing in on a shared dysfunction in the T cell response.
So what's actually happening with the T cells?
Well, in a healthy immune system, your T helper 1 and 2 helper 2 cells operate in a nice, balanced feedback loop.
Keeping everything in check.
Exactly. But in both LS and morphea, that balance is just shattered.
And what does that imbalance do?
It triggers a cascade of profibrotic cytokines. These cytokines are essentially chemical messengers that act like a malfunctioning alarm system.
Oh, I see.
They flood the tissue and aggressively activate the fibroblasts, which are the cells responsible for manufacturing collagen.
So the fibroblasts just lose their regulatory brakes.
Yeah, they begin overproducing extracellular matrix proteins uncontrollably. We also see the presence of shared autoantibodies targeting those exact same matrix proteins.
Let me try another analogy here. Think of the immune system's targeting mechanism like a highly advanced but corrupted GPS system.
Okay, I'm following.
The overarching glitch, the T-cell imbalance, and the cytokine flood is identical. But how the disease manifests depends entirely on where the corrupted GPS directs the attack.
That's a brilliant way to frame it.
So in some patients, the GPS targets the fibroblasts in the superficial ZIP code, like the upper dermis. The local tissue breaks down, and we label it lichen sclerosus.
Right. And in other patients, the GPS targets the fibroblasts in the deep dermal ZIP code. The fat layer turns rigid, and we label it morphea.
But in the exceedingly rare case of our 60-year-old patient...
The corrupted GPS dropped a pin on the entire vertical block.
Wow!
Yeah, the cytokine flood triggered the superficial fibroblasts to cause atrophy and the deep fibroblasts to cause sclerosis simultaneously.
Which fundamentally challenges everything we thought we knew about the boundaries of these conditions.
It really does.
I mean, we started this deep dive looking at how to differentiate the superficial crinkles of extragenital LS from the deep inflammatory lilac rings of morphea.
We walked through the mechanical toolkit, using polarized light to spot twisted capillary loops, and using biopsies to find armies of lymphocytes or swollen collagen pillars.
And we established the severe clinical stakes of misdiagnosis, the critical divergence between preventing permanent limb contracture and monitoring for malignant cellular changes.
Right, but the reality of that shared hybrid lesion changes the entire narrative.
It does, and if you, or someone you love, ever faces a stubborn, unexplained hardened skin plaque, you now know exactly why a visual check in a brightly lit exam room just isn't sufficient.
You understand the complex, hidden mechanics operating below the stratum corneum.
This knowledge is basically a tool for self-advocacy. You understand the necessity of asking your clinician about dermoscopy patterns.
Absolutely. You know the value of requesting a biopsy to determine the exact histopathological reality of your tissue, because the naked eye cannot differentiate between a superficial glitch and a deep foundational collapse when the surface is just completely homogenized.
Exactly. And as we wrap up today's deep dive, I want you to consider the broader philosophical question this medical mystery raises.
It's a big one.
It is. In medicine, we rely heavily on nomenclature. We place immense trust in our ability to categorize biology into neat little boxes with distinct Latin names.
Right. We have a textbook chapter for lichen sclerosus and a completely separate chapter for morphea.
We give them different diagnostic codes and different patient support groups.
Yeah.
But if two diseases, historically defined as entirely separate entities, shared the exact same genetic vulnerabilities, the exact same T-cell dysfunction, the exact same profibrotic cytokine pathways, and can even merge to occupy the exact same microscopic slice of human tissue.
Are diagnostic labels actually capturing biological reality?
Exactly. Or are morphea and lichen sclerosus just arbitrary human-made boxes that nature is slowly proving to be an illusion?
It points toward a really fascinating future of personalized medicine, a future where we might stop treating the name of a disease entirely.
Imagine that. Instead of arguing over whether a plaque is technically LS or technically morphea, we will simply map the corrupted GPS coordinates and target the specific immune glitch happening inside that unique patient.
It's incredible to think about.
It makes you wonder, the next time a specialist points at a lab result and confidently declares, there it is, are they pointing at the absolute truth, or just the best flawed label we currently have for the murky, overlapping waters of the human immune system?
Something to think about for sure.
Definitely. Thanks for joining us on this deep dive.